Let me know. Hopefully you guys can see that. So Charlie and I are both going to be talking a little bit about some of the barriers to help seeking amongst health social care workers in today's talk. My details are up there. Like Neil said this morning, we've done exactly the same thing. We've made all of our research, all our clinical guidance, everything freely available to absolutely everyone. So if you want to grab any of the research or any of the stuff that this talk's based on, just head on over to our website at traumagroup.org and you can grab everything for free there. So as Neil started speaking about this morning, there's a very clearly established level of distress in healthcare workers, certainly measured by a few of our groups at the beginning of the pandemic. As Neil said, a lot of this is cross-sectional. It was captured at a certain point in time, so we can't say what percentage of people will go on to develop kind of diagnosable mental health problems, but there was certainly a huge amount of distress in the early part of the pandemic experienced by frontline healthcare workers. And some early research of ours showed that about 58% of people met criteria for anxiety, depression or PTSD as measured on clinical instruments shortly sort of after the peak of the first wave. So we know that the distress was there. What was really interesting was that did not correspond with help seeking from psychological support services. So what we're going to try and do in this talk is delve into perhaps what some of those barriers were in a little bit more depth. So what did we do? We went out and we spoke to a bunch of people. We spoke to frontline health and social care workers, so doctors and nurses, but not just doctors and nurses. We spoke to porters, to cleaners, administrators, mortuary workers. We spoke to all these different people working on the front line to get their opinions about their experiences about the pandemic and also their experiences about support that was or wasn't provided to them. We also spoke to mental health professionals. Now, we saw an entire workforce of mental health professionals who were rapidly surged into providing support for frontline health and social care workers very early on in the pandemic. And this was largely a workforce who hadn't had any previous experience of working with health and social care workers and had pretty much no experience of kind of the medical procedures or kind of COVID, infectious viruses, that kind of stuff, and was suddenly thrust into this world. They were working with health and social care workers who were doing this work. Even amongst our colleagues that worked in physical healthcare settings, perhaps even provided support into ICUs and other hospital departments, their role was traditionally working with patients and alongside the staff to support the patients and their families. Suddenly these mental health care professionals were treating staff as their clients. It was a very different world for them to suddenly step into. We recruited people purposefully through social media and our health and social care colleagues. We collected data quite early on in the sort of early post-peak phase last year, and we analysed all of our qualitative data using thematic analysis. We've got a whole bunch of quantitative data as well. It's all on our website. I'm just going to be talking mostly about the qualitative data today. So one of the first barriers that we pulled out was this sense that kind of, well, it's not for me, is it? This sort of lack of awareness or prioritisation of people's own mental health needs. So it's largely health and social care workers fail to recognise their own mental health care needs. It just wasn't something that they really paid attention to. And even when they did pay attention to it, they didn't really sort of prioritise it. In fact, they quite often minimised it. And this was taking place in a culture in health and social care settings where little attention has traditionally been paid to staff mental wellbeing. So it wasn't something unique about the pandemic. It was quite a long-standing tradition, health and social care workers not really having the time or space to talk about their own mental health and wellbeing. And there was this strong belief that support services weren't for people like them. We had doctors say to us, well, those services are for the nurses, aren't they? We had porters and cleaners saying, well, that's for the doctors and nurses. So there's this sense of, it's for someone else, it's not for me. What was particularly interesting is that this wasn't unique to the health and social care workers. We actually found exactly the same thing in the mental health professionals we spoke to. So all the mental health professionals that took part in our research had made significant sacrifices to their own well-being in doing this work. They'd stepped up, they'd stepped into this new arena, which they knew little about before. They were working extra hours, they were working outside of normal hours to try and connect health and social care staff. And this came at quite a big cost to their own well-being. But not a single mental health care professional we spoke to had thought about their own mental health needs, given all the sacrifices they were making during the pandemic. Here's a couple of quotes for you, one of whom was actually from Sydney. We've used pseudonyms throughout, but was actually from someone who was tasked with providing mental health support to health and social care colleagues. When we asked, have you sought any help yourself, actually said, it never even crossed my mind. And then Nicole, a clinical psychologist in our sample, similarly said, even when you think about your mental health, there was a sense that it shouldn't be a priority, but it wasn't a priority. I'm not a frontline worker. I'm not a nurse. I don't need to take any time out. So it wasn't unique to the health and social care workforce. We really saw this in the mental health professional workforce as well. There was also real confusion and lack of clarity about what these services were and what was out there. So the mental health professionals we spoke to talked about there being a lack of protocols, a lack of procedures or established service pathways for providing support to health and social care workers. We found a lot of kind of uncertainty or lack of knowledge about links between occupational health and psychological support. So people were setting up pathways with the best intentions and were not often well integrated with each other or with other existing services. There was also a lack of specialist knowledge. A lot of the mental health care professionals stepping into this space, again with the best intentions, didn't know a lot about health and social care staff. They didn't know much about the culture or the medical language or the terminology, the things that they were doing. So it was a rapid and steep learning curve for the mental health professionals in a world that they just didn't necessarily know much about. And this led, perhaps unsurprisingly, to quite a lot of inconsistency in the service provision. So this was experienced by health and social care workers as a real sense of uncertainty. Kind of people said to us, you know, I just don't know what's available. I don't know what's out there. And a lot of confusion about how, when, and where to actually seek help. And even those that did try and access help couldn't always get hold of it. People couldn't get hold of help outside of hours if it corresponded with their shift pattern. And that was different to when the mental health workers were working. Or they'd call a helpline, or they'd call a support service and just get no answer because those services might have not had sufficient resources and support. So even those that did try and seek support couldn't always get hold of it. There's a couple of quotes here. The first from someone working as a PWP in IAP that really captures, I think, that uncertainty, that sense of like, you know, am I doing the right thing? Is this the right thing to support these people? We don't have established protocols. And the second, actually, from a consultant who was working in ICU and the peak of the pandemic, who said, I don't even know what the numbers are. I know they're out there, but I don't know them, and I don't know what number I would call. We also found, which was perhaps quite unique to the COVID context, was this sense of remote working and mental health professionals and mental health support services being out of sight and out of mind. So working remotely definitely impacted on as a barrier to people accessing support. This, quite interestingly, what this led to amongst the mental health services being offered to people was an over-reliance on communicating about how to access them via email. We're talking about trying to help a workforce who are working 12-hour shifts in ICU are not sitting at a computer checking their emails throughout the day. And even amongst staff who would check their emails and perhaps find out about this information, there's a whole group of healthcare professionals who don't have computer-facing roles. The cleaners, the porters, mortuary workers, you know, they're not going to be people who are checking and accessing emails. And furthermore, a lot of these members of staff are not employed directly by the NHS. They're employed by agencies. So they don't even have an NHS email. So much of this information was sent out by NHS emails. So this large swathes of the frontline healthcare workforce never even stood a chance hearing about this information. So services not immediately visible to health and social care workers were much less likely to be used. And this led to mental health professionals feeling quite guilty about not being there in person, and not feeling like they kind of weren't on the front line with their health and social care colleagues. There's a nice quote here from a mental health practitioner in ambulance service. It really captures that sense of, you know, just trying to reach people by email when that's not going to be the main method of communication is really hard. How much easier it is if you can have a conversation face to face. We also found a number of problems around accessibility and quite practical barriers to engaging in support. Timing and access were big barriers. So literally, when were frontline health and social care workers in the peak of the pandemic going to go and speak to a mental health professional? There not going to get an hour out in the middle of their shift whilst looking after 2, 3, 4 very ill patients who are critically dependent on their care. And yet at the end of the shift, you know, is it really fair on the workers at the end of a 12-hour shift to ask them to go and have an appointment then? And even if they did want to do that, actually, you know, getting to somewhere else, if it wasn't available close to where they were working, if they had to travel to another service or something like that, all presented quite real practical barriers to people getting help. But also a lack of confidential spaces. So even when mental health professionals were in there in person, they had to socially distance. They couldn't always meet with their health and social care colleagues in particular spaces. Or even if they were working remotely, there often wasn't a confidential space for a health and social care worker to go and sit on a computer and have a conversation about what they were thinking and what they were feeling. There were also particular technological barriers. I've alluded to some of these. Not everyone had NHS emails. Not everyone sits in front of a computer, so could access this support or attend remote sessions. And all of these barriers really exacerbated previously existing inequalities in access. The people who were least likely to access support were the more peripheral healthcare workers, who traditionally also come from more minority, marginalised ethnic groups. There's a nice quote here from an A&E nurse that just captures that sense of, you know, people had good intentions, but the reality of trying to access help when you're working like that is just not really achievable. And then finally, very relevant for today's conference, is this idea about reluctance and stigma that people perceived in terms of accessing help. First and foremost, health and social care workers were not wanting to be seen to not be coping. I know there's a lot of controversy about wobble rooms and lots of well-intentioned ideas about offering wobble rooms for health and social care staff. No one wanted to be defined as having a wobble, so people did not go and use these wobble rooms. And mental health professionals were not exempt from this as well. The mental health professionals did not want to say that they were struggling. We asked the mental health professionals who are providing this support in our sample where they themselves would get support from, and they said without exception, I'd speak to my peers, or I would speak to my supervisor or my manager. And then we'd say to them, well, have you spoken to your supervisor? Have you spoken to your peers? And they nearly all without exception say, oh, actually, no, I haven't seen them or been too busy. So mental health professionals were not exempt from the same kind of stigma and reluctance to actually saying, this is really hard, I'm struggling, and actually seeking help for those reasons. And we've talked about this a lot this morning, which has been music to my ears, that these narratives around individual resilience and individual well-being perpetuate this idea that the responsibility lies with the individual to manage their own health and well-being, that somehow it's their responsibility not to be harmed by working in a harmful environment. So you'll probably notice from all the themes we've pulled out today, and they're very much inductive themes coming from the data, that most of them are not around individual factors. They're much more around structural and systemic barriers to people actually getting help. A quote here from a junior doctor which I think again captures that sense that people don't want to say, I'm struggling. There's been some fantastic work around the kind of "it's okay not to be okay" campaign. It's been very well received, but we've got a long way to go to really shift this culture around sort of acknowledging mental health and people struggling in the workplace, and things that we might be doing to try and manage it might inadvertently actually be perpetuating it. So where next? That's the topic of conversation this conference today, so I won't answer that question, but I will point out a few things that we've pulled out of our research before handing over to Charlie. So we certainly think that there needs to be more mental health awareness training amongst in kind of health and social care settings. I know Neil talks a lot about managers, but actually this needs to be something that takes place across the board for everyone, not just sort of managers, senior nurses, doctors. It needs to reach out to all the different workers in the peripheral workforce as well. Systems of support, they need to be coherent, they need to be consistently communicated and easily accessible. People need to know what's out there and how to go about getting it. Staff need protected time during working hours to access this support. Doing that communicates that mental health is an important part, their well-being is an important part of their role. Not doing it communicates exactly the opposite. There are structural and systemic barriers, which we've talked about, which need to be addressed. And we need a lot more collaboration, consultation, and co-production of these support services. We shouldn't just be doing wellbeing to health and social care workers. We need to be working with them and co-producing these services and evaluating them with them. And then finally, thinking about mental health professionals, we need to think just as much about wellbeing support for mental health professionals as we do for health and social care workers. We need to prioritise that. We need to build in systems of monitoring and make sure it happens in supervision and through supervision of supervision. And finally, we need to do so much more research on the mental health of mental health professionals. It seems rather ironic that it's a huge area neglected in our very own field. So thank you very much. I'll stop there